I am here with my marvelous wife who is going to spout her wisdom on this whole endocrine thing. Now, some of you might be like, well, I'm cool with the endocrine. Some of you might be like me and like, panic. So, if that's the case, or maybe you're somewhere in between, I'm going to give you Shay. Here we go. Peace.
Okay. Um, I don't know why Mike thinks that it's such wisdom. It's all in your book. But what I want to do is just try and explain to you guys how it actually works. You already have my teaching notes, so that's going to help you to, study, to know what to focus on for the test. But hopefully what I'm going to do with this is to actually explain it to you and not just read it to you, but explain it to you. So the first thing I want to do is I want to start with I want to start with the actual posterior pituitary gland. All right, so the posterior pituitary gland, and everything that I talk about, if you think about it, you have the gland that we're talking about, and then you have the hyper amount up here and the hypo amount down here. So what you got to think about is when it's hyper, you want to make it to stop producing to bring it back down to normal. Or when it's hypo, you want it to produce more so you can bring it up to normal. So again, if you think of every single gland that the pituitary, or every single gland of the endocrine system, you're going to have a normal in the middle, you're going to have a hyper on top, and a hypo on the bottom. So if you bring, normally what happens is when there is a hyper state of the gland, it's producing too much hormone, and we want to do something so that it no longer produces too much. Or when there's a hypo, we want to either add to it by adding some kind of synthetic hormone, or we want to stimulate it somehow to produce more to bring it back up to normal again. All right. So if you can think of the endocrine system like that, in hypers and hypos, in that what we're trying to do is we're trying to get the hyper back down to normal or the hypo back up to normal, it's going to make more sense to you. So if we start with the pituitary gland, the posterior pituitary gland, the main purpose of the posterior pituitary gland is to produce anti-diuretic hormone. Now, what you need to know is that another name for anti-diuretic hormone is called arginine vasopressin. All right? That's synthesized in the hypothalamus but secreted by the posterior pituitary gland. I'm saying it because that's a possible test question, and you need to know that. Or at least when I was teaching it, it was a possible test question for me. So then here we have it. The gland is the posterior pituitary gland, and the hormone that it secretes is anti-diuretic hormone. So you got to think about this. What does anti-diuretic hormone mean? Anti means against, diuretic means peeing or diuresing, but in this case specifically peeing, and then it's a hormone. So it's a hormone that is against peeing. All right, so when you think about it like that, you can kind of start to think of it in those terms. So when the posterior pituitary gland is in the middle, is producing like it needs to, it produces anti-diuretic hormone. When it's in hypo form, that is called diabetes insipidus. All right? Diabetes insipidus has nothing to do with diabetes mellitus. It has nothing at all to do with sugar or the pancreas or anything else. Diabetes insipidus happens when the posterior pituitary gland does not produce enough hormone that is against peeing. So think about it. If there is not enough hormone that works against peeing, what's going to happen is your person with diabetes insipidus is going to pee all the time because there's no hormone that stands in opposition to the peeing or stands against the peeing. And so you have an anti-diuretic hormone, and when it's not enough, it's called diabetes insipidus, and that person is going to have a large amount of urination. They're going to be peeing throughout the day. And when I'm talking about multiple peeing, I'm not talking about peeing like I had to go to the bathroom 3 or 4 times today and that was inconvenient. I'm talking about they miss class, they miss work because they're peeing all the time. Okay? And because of that, their urine is very clear. It's not pale yellow, it's clear because it's the specific gravity is very low on that. Okay? It's not concentrated at all. As a matter of fact, people with diabetes insipidus can urinate anywhere from 3 to 15 liters a day. That's how much that it causes. So the signs and symptoms of diabetes insipidus would be frequent urination, polyuria, nighttime urination, nocturia, because they're constantly peeing all the time because there's not enough, there is a lack or a hypo amount of anti-diuretic hormone. Again, anti-diuretic is anti-peeing hormone. And because there's not enough of it, the body just keeps peeing and peeing and peeing and peeing because there's not enough anti-diuretic to stop it. All right? And so you're going to have low specific gravity, and it's going to make the urine diluted and light in color. Okay? And because that person is peeing all the time, guess what? They're going to be thirsty as crap, okay? So they're constantly thirsty, and they consume large volumes of water. So again, if you think about it, if they're peeing anywhere from 3 to 15 liters a day, then they're going to consume at least that much in fluids. So 15 liters of fluid would be equivalent to 7 2-liter bottles of fluid a day. That's a lot to drink in. Okay? So basically then, what's going to happen is they're going to say, how do we get this anti-diuretic hormone, this person that doesn't have enough of it, how do we get it to produce more? So the way that we get this hypo amount of anti-diuretic hormone, diabetes insipidus, the way we bring it back up to normal is we actually have to give them synthetic vasopressin. Remember, vasopressin is another name for anti-diuretic hormone. So literally, you're literally giving them synthetic anti-diuretic hormone. And as you give it to them, it brings that hypo state back up to the normal state. So you have now an equal amount of the posterior pituitary gland is now producing an equal amount of anti-diuretic hormone. I don't know if that makes sense to you. I'm hoping that it does. Some of the ways that they're going to test to see whether or not that patient actually has diabetes insipidus is they're going to do maybe a CT scan or an MRI that can show maybe a pituitary tumor, and they're going to do urine specific gravity tests, and they're going to do some lab tests. So I hope that that makes some sense to you guys there. And then, like I said, the way that they're going to actually be able to bring that diabetes insipidus, that lack of antidiuretic hormone, the only way that they're going to bring it back up into balance again is to give them synthetic vasopressin. All right? So, usually, synthetic vasopressin is called desmopressin, and it comes in the form of a nasal spray, and it's usually used twice a day. All right. So, other drugs like diabetes will help the kidneys to respond better to ADH, and some thiazide diuretics may actually decrease urine flow in the absence of antidiuretic hormone. But the typical way to bring a hypo antidiuretic hormone, diabetes insipidus, back up to the normal state is vasopressin or desmopressin, and it's given as a nasal spray twice a day. All right, so that was the hypo side of the posterior pituitary gland and antidiuretic. So hypo, when it's too little, it's not producing enough, and it's not producing enough antidiuretic hormone, so that person's going to pee. Okay, we got that. Now, what happens then if the posterior pituitary gland starts to produce too much antidiuretic hormone? That means that now there's too much antidiuretic hormone, and that's called a syndrome of inappropriate antidiuretic hormone, or SIADH, syndrome of inappropriate antidiuretic hormone. And what's happening then is the posterior pituitary gland is producing too much. So now you have so much hormone that's against peeing. What do you think is going to happen here? You guessed it. They're going to not be able to pee off or diurese all that extra fluid. So what's going to happen is there's so much hormone that's telling the body you can't pee, that it doesn't pee, and all of that fluid that it's taking in has to be deposited elsewhere in the body. So some of the signs and symptoms you're going to see actually have to do with signs and symptoms of fluid overload. So you're going to see weight gain. You're going to see dilutional hyponatremia. That means that their salt level in their their salt level in their blood is going to be low. All right? And then their serum osmolality is going to be less than 275. And you got it, instead of the urine being dilute like it was in hypo, now it's going to be extremely concentrated because the body can't pee all of that out. And so that urine is going to be highly concentrated, and the specific gravity is going to be increased. All right. So I'm hoping that this makes some sense to you. And usually, how they are going to measure whether or not this person has SIADH or hyper ADH or well, that's what it is, hyper ADH. They're usually going to do some kind of serum and urine sodium levels and osmolality levels, and then they're going to actually check the serum for the ADH. And if it's high, then they know, obviously, that this person has syndrome of inappropriate antidiuretic hormone. All right? Usually what happens is there's some kind of tumor in the posterior pituitary gland that's pushing and causing the posterior pituitary gland to keep producing antidiuretic hormone. So in order to bring this hyper state back down to the normal, they're usually going to have to do some kind of testing where they remove the tumor that's causing it. Usually hyper amounts of hormone are produced because they're produced because of some kind of tumor or something like that. Okay, so that, my friends, is the posterior pituitary gland. Also remember that the posterior pituitary gland produces oxytocin, and oxytocin is what's responsible for uterine contractions and for milk production. So just remember that as well. All right, so just to review, you have the posterior pituitary gland that produces antidiuretic hormone. When it doesn't produce enough antidiuretic hormone, then it's called diabetes insipidus, where there's going to be polyuria, there's going to be polydipsia, and nocturia, and your specific gravity is going to be low, your urine is going to be dilute, and that is diabetes insipidus. Again, you have the posterior pituitary gland. It produces ADH when it's in a normal state. When it produces too much ADH, it produces a hyper state, and that is called syndrome of inappropriate diuretic hormone. That is just the opposite, where that person is not going to be able to pee very often, so that's going to cause them to have fluid overload. It's going to cause them to weight gain without the edema associated with it. Their urine is going to be very concentrated, and their serum or their urine osmolality is going to be high. Okay, to bring diabetes insipidus back up to normal, they're going to usually they use desmopressin. That's administered nasally twice a day. And to bring syndrome of inappropriate diuretic hormone back down to a normal, they usually have to remove the tumor that's causing the overproduction of it. All right. Now we're going to talk about, sorry, I'm flipping through the book. Now we're going to talk about the growth hormone, all right? Somatotropin. Here's a little tip for you guys that when I told Mike, he was like, it just was like a light bulb going off for him. But any kind of hormone that has a tropin in it, it comes from the pituitary gland. So you have growth hormone, it's somatotropin. That means that it's coming from the pituitary gland. You have adrenocorticotropin stimulating hormone. That, again, the tropin part means it's coming from the pituitary gland. You have thyroid stimulating hormone, which is known as thyrotropin. Again, it's coming from the pituitary gland. So anything with a tropin or a tropic to it means that it comes from the pituitary gland. All right, so one of the hormones that the anterior pituitary gland secretes is growth hormone. Okay, so you have growth hormone, which is responsible for growth. All right, obviously, if you don't have enough growth hormone, then you have something called dwarfism. And if you have too much growth hormone, then you have something called gigantism, okay? So, or acromegaly, all right? So let's talk about when there isn't enough. When you have a hypo state of growth hormone, then it's called dwarfism. And what that is, it's called short stature syndrome, all right? Children may grow only 3 to 4 feet in height, but they have all normal body proportions, all right? and sexual maturity is going to be slow. All right? So, in adults, when they have growth hormone deficiency, it's going to make them feel tired, weak. They're going to have excess body fat, decreased muscle tone, and bone mass, and high cholesterol, and that's kind of how that is. And really and truly, the only way that you're going to bring this hypo state of dwarfism up to a normal state is through administration of somatotropin. Now, somatotropin, if it's given in a child and you catch it early enough, it may help them to grow to normal proportions. But growth hormone in an adult, once that epiphyseal cell is closed, growth hormone in an adult isn't going to cause them to grow more. Okay? So that's hypo, bringing it up to normal. They're going to add growth hormone to it. Hypo, adding the growth hormone, brings it back up to where it should be. Then the other side of that is acromegaly, where people have too much growth hormone. And what happens when people have too much growth hormone is it causes children to grow tall. But if it happens after the epiphyseal plates are closed, then what happens is the face will elongate, and the jaw becomes very square and long. There are, like Andre the Giant, he had acromegaly. There's a couple of famous actors that we've seen in different movies they always play the giant, obviously, because they have acromegaly. But their features are very distinct because their jawline is very, their face is very elongated, their jaw is very square. But these people, the nose, the jaw, the brow, the hands, and feet, they all enlarge. Okay? And the teeth often become displaced because the jaw is enlarging and it's loosening up the gums and the teeth that are held together by a more compact jaw. Okay, headaches are really common with this. Usually it's, again, whenever you have too much, it's usually because you have some kind of tumor that's pressing on the pituitary gland in just the right place to produce an overabundance of growth hormone. So usually, in order to fix a hyper state, they're going to have to remove the tumor and bring it back down to the normal growth hormone. So always expect that when somebody has a hyper state of a hormone, they're either going to have to irradiate the tumor, or they're going to have to surgically remove the tumor, or they're going to have to give it some kind of medicine that suppresses the tumor or shrinks the tumor so that it doesn't put that kind of pressure on the gland that's in question. All right, so that basically describes the growth hormone. Anterior pituitary gland, one of the things that it produces is growth hormone. When you have too little growth hormone, it's called dwarfism, and it's little person stature, where they don't grow very tall, but they have normal body proportions. And then you have the opposite. When it's too much, then you have acromegaly. And if it occurs in children, then the children grow very tall. If it happens in an adult, after the epiphyseal cell has been closed, then they have what we call acromegaly. Okay, so like we said, that treatment is aimed at the cause. Okay, so in order to bring it back up, hypo, back up, they're going to give that patient something called somatoline depot or octreotide or sandostatin or somatoline depot. Okay, what those do. Oh, you know what? I just told you guys backwards. I am so very sorry. The somatoline depot or the sandostatin is actually what they do to decrease. It's what they do to decrease the growth hormone and bring it from a hyper state back down to normal. I'm going to say that again because I messed it up originally. I just want you guys to make sure you have it. The somatoline depot or the sandostatin, they're injectable medications that cause a decrease in growth hormone. So that is what they're going to do. That's the first line of defense for somebody that has an excess of growth hormone. If that doesn't work, then they're going to do radiation. If that doesn't work, then they're going to do a procedure called a hypophycectomy, which is where they go in and they remove part of the pituitary gland or all of the pituitary gland. And I want you guys to just go through your book on page 892 to 893 and really look at the postoperative care for a hypophycectomy, because it's usually done up through the nose where they go in with clippers or a needle and they go up through the nose and they clip it or they remove it. Okay, so there's some specific postoperative care that you guys should look at. Alright, so we're still back here on the anterior pituitary gland, and we talked about too much or too little of growth hormone. Now we're going to talk about the pituitary gland stimulating TSH. So the pituitary gland produces TSH, which is the thyroid stimulating hormone, and then the thyroid produces T3s and T4s. So this is how it works. You have the pituitary gland that releases thyrotropin or TSH, and its whole job is to wake up the thyroid. So the pituitary gland sends out TSH. The TSH comes down to the thyroid and says, "Hey, little thyroid, wake up. It's time to produce." And so then it starts to produce some T3s and T4s. So the T3s and T4s, they're down here at this low level, and it's kind of like right here. But what happens is that as the T3s and T4s start to produce more and more and more, the TSH will stop producing, because it's a negative feedback system. So when T3s and T4s are low, TSH is going to be high. When TSH is low, T3s and T4s should be high. It's this negative feedback loop that you have going on right there. Alright, so the T3s and the T4s, what their responsibility is, they have three main responsibilities: regulating metabolism, regulating heart rate, and regulating body temperature. Or they help to regulate those three things. When the pituitary gland stimulates TSH and the TSH works like it should, and it stimulates just the right amount of T3s and T4s so that there's a balance there, that's called euthyroid. Euthyroid, meaning that it's in balance or it's in harmony. It's right where it needs to be. Okay? So remember that the T3s and the T4s of the thyroid gland are responsible for three things: metabolism, heart rate, body temperature. Alright, so when it doesn't produce enough T3 and T4, you have hypothyroidism. Alright? Hypothyroidism thyroidism, remember, when it's in balance, it helps to regulate metabolism, regulate the heart rate, and regulate body temperature. Well, when there's not enough, that means that metabolism is going to tank and that person's going to gain weight. When there's not enough, that means the heart rate can't be kept up at the normal balance, and that's going to take, so that person's going to have bradycardia. When the last thing that the thyroid T3s and T4s do, remember we said that the T3s and T4s regulate metabolism, heart rate, and body temperature. So when you don't have enough, that person has an intolerance to cold. They get cold very easily and they just can't get warm. So those are the three main key signs and symptoms then of hypothyroidism, is that your metabolism tanks, so you gain weight, and you get constipated because everything moves slower. Metabolism slows down. You get cold. Your heart rate slows down. You get constipated. Everything is slow. All right? When you have too much T3s and T4s, then everything is opposite. Your heart rate increases. Your metabolism increases to the point where you're eating like a fool, but you can't gain any weight. You get extremely hot very easily. Okay, when that happens, that person sometimes gets mistaken for a drug addict because they become very jittery because everything is sped up. Just like in hypothyroid, everything is slow. In hyperthyroid, everything is quick. Quick, 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 quick. Think of a little busy bee. The bumblebee is just buzzing everywhere. They're not stopping for very long. A little hummingbird just going, going. Moving very, very fast, okay? And they become very jittery, very anxious, very hyper. Their metabolism, they can't gain weight. They're eating like a fiend, but they can't gain weight. And because their metabolism is juiced up, then their body becomes very hot, and they can't stand heat. And so what can happen, though, is if that hyperthyroid state isn't controlled, it can spiral out of control into what we call a thyrotoxic storm, okay? Thyrotoxic storm. And when that happens, it takes all the signs and symptoms of hyper and it explodes them. So instead of having an increased metabolism, now it's super increased. Instead of your heart rate being increased and elevated to like 100 to 110, now we're talking 140, 150. It's going super fast. Your body temperature, instead of running, normally like a 99 and you just have an intolerance, that's where your temperature goes out of control and it's extremely hot, 104, 105. Okay, that's called a thyrotoxic crisis. It's where you take all the signs and symptoms of hyperthyroidism and it just spirals and spins out of control. And it exploits all of those signs and symptoms and it makes them 100 times worse. All right. Hypothyroidism, another name of that you might hear or another symptom of that is called myxedema, which is the type of edema that occurs in the connective tissue throughout the body. Okay, so remember, hypo slows everything down. Your metabolism, even your mental clarity is going to be slowed down. So hypothyroidism, you're going to have low levels of T3s and T4s, high levels of TSH, and everything is going to be slowed down. Okay? So, Um, I'm just rereading the signs and symptoms real quick so I can make sure that I'm telling you. So in order to fix hypothyroidism and bring it back to a normal balance, that person is going to have to take a synthetic thyroid hormone called synthroid or levothyroxine, and they're going to have to take it every day for the rest of their life. And that should be taken in the morning before they eat. And then that helps to bring their T3s and T4s back up to a euthyroid or a balanced state. Okay, when they have hyperthyroidism, remember it's usually caused by some kind of tumor or some kind of overproduction. So sometimes what's going to happen is that person that has hyperthyroidism is going to end up having to take some medicine called Thyrosil. All right? And what that does is it actually irradiates the thyroid. Okay? It irradiates the thyroid. So the medications that you'll probably hear about is called propylthyracil, okay, or PTU, or tapazole, which actually inhibits thyroid hormones, T3s and T4s. So it inhibits it, it brings down the T3s and T4s and brings it back up to that normal euthyroid state. If those two medicines don't work, the PTU and the tapazole, if those medicines don't work, that's when they're going to give radioactive iodine and they're going to irradiate that thyroid. But this is what happens. Once you irradiate the thyroid, then it's no longer going to produce T3s and T4s, and the chance of that person having or the chance of that person then going from a hyper state down to a hypo state and ending up on some kind of synthroid or levothyroxine for the rest of their life is very high. If the radioactive iodine doesn't work, that's when they'll go in and they'll do a thyroidectomy. Now, a few things about a thyroidectomy that you really need to be careful of is that you always want to check for bleeding. So when somebody has a thyroidectomy and they're constantly swallowing, that's usually a sign that there's bleeding on the inside. The other thing you want to worry about is that you have a trach kit by the bedside, because if that thyroid where they removed it starts to swell up, the tissue around there, it can block their windpipe very quickly. So always make sure that that you have a trach kit by the bedside and that you check for bleeding, and the common sign of that is constant swallowing. Okay? If they have a thyroidectomy, then you need to teach your patient that they're going to be on thyroid replacement hormone for the rest of their life. Now, the other thing that you need to worry about is that if that person has a thyroidectomy, remember that the thyroid is in the shape of a bow tie. And on the ends of each of the bow tie, there's 4 parathyroid glands. So if we take out the thyroid and we don't make it a point to leave the thyroid glands in or reimplant them somewhere else in the body, then not only are we taking out their thyroid and having to replace the thyroid hormones because there's no more thyroid, now we're messing with the parathyroids, and we're going to have to actually give them hormones or medications that would take the place of the parathyroids. And so that's what we're going to talk about now. We're going to talk about disorders of the parathyroid glands. So remember, when we're talking about the parathyroid glands, there's really 4 parathyroid glands. 2 on the left side, 2 on the right side. All right, so what does the parathyroid gland regulate? The parathyroid gland regulates calcium, the amount of calcium that is in our serum or in our blood. So, serum calcium is what the parathyroid gland regulates. All right. Okay. So you have, again, you're still talking about the pituitary gland. So the pituitary gland is going to secrete PTH, which is parathyroid tropin hormone, PTH, parathyroid tropin hormone, okay? So that's, again, from the pituitary gland. The parathyroid hormone stimulates the parathyroid glands to respond to low serum calcium levels, all right? So when calcium levels are low, PTH is high. As calcium levels increase, PTH lowers, and then you're going to get that U state where everything is in balance. All right? So, when our body doesn't produce enough PTH, that means that our calcium levels, if it's not producing enough PTH, our calcium levels are going to be very, very low, because all that calcium is going to stay in the bones and it's not going to be in the serum. So the PTH level is going to decrease, and the calcium in the blood is going to be very low. And so what kinds of problems do you think is going to happen when we don't have enough calcium in our blood? So, think about this. Calcium is responsible for strong bones, but it's also responsible for healthy muscle contraction and electrical stimulation, because it's the calcium that helps to bring the muscle fibers together to cause a contraction. If you have weak calcium, then your muscles aren't going to be able to stay together for a long enough time to have a good contraction. Instead, you're going to get a lot of twitches, a lot of misses, but not a lot of good, strong contractions. All right? So, numbness and tingling of the fingers or periorbital areas, muscle spasms, and twitching. Those are all signs that you have hypocalcemia. Two things that you need to worry about here is a positive Ptec sign and a Trousseau sign. All right. Trousseau sign is where you put a blood pressure cuff around the arm, and the arm will twitch like a fish. Think of trout or Trousseau, and that's how you're going to get that. Chavastic sign is where you tap on the facial nerve and you see twitches. All right. Chronic hypocalcemia can lead to lethargy, calcifications in the brain, cataracts, and convulsions. That's chronic. So once they start to have hypocalcemia, once that PTH falls off, the calcium in the serum calcium is going to fall off, and then it's going to start to produce those signs that we said. Signs like neuromuscular irritability, numbness, tingling of the fingers and perioral area, muscle spasms. All right, that's all hypocalcemia. Now, what are we going to do to bring hypocalcemia back up to a normal state? Like everything else so far, we are going to have to give that patient some kind of calcium, and what that is it's IV calcium gluconate. IV calcium gluconate brings low levels of serum calcium back up to a normal state. I hope to God this is making sense to you. All right, now we have just the opposite. So we've had hypoparathyroidism, which just very basically means hypocalcemia. Now we're going to have just the opposite, which is hyperparathyroidism. All right? So what do you think is going to happen when hyperparathyroid happens? Well, if hypoparathyroid causes a decrease in calcium, then hyperparathyroid is going to cause an increase in calcium. All right? So what's that going to do, though, is that means that all of the calcium that's going to be in our bones, or that should be in our bones, is going to come out of our bones and into the blood. So what do you think some of those signs and symptoms are going to be if the calcium that should be in our bones are coming out now and hanging out in the blood? That means that our bones are going to be weak, right? There's going to be some fatigue, maybe some confusion, nausea, vomiting, kidney stones, cardiac dysrhythmias. Those are very key things here. All right? And we're going to start to have some pathological fractures because now our bones are weak, because the calcium, which should be in our bones, have come out of our bones and are into our blood, and that's what's giving us that high calcium level in our blood. Hyperparathyroidism. So then the question is, how do we get this high level of calcium, or this hypercalcemia or hyperparathyroidism? How do we get that back down to a balanced state again? What are we going to do? Well, there's a few things that we're going to do. One of the things is they're going to try and lower, they meaning the doctors, are going to try and lower that by maybe diluting it out of the system. So they're going to try and give a Lasix, just furosemide, and they're going to try and bring that back down. All right, so that's going to help the renal excretion of the calcium. Other things that they might do is they're going to give Fosamax or calcitonin, and that's going to prevent the calcium from releasing from the bones and coming into the bloodstream. All right, so at this point, I am done with the pituitary gland, and I'm ready to move on to disorders of the adrenal gland, and I will do that in the next video. And again, I hope to God this is helping you guys. I'm sure that you have heard this until you're blue in the face, but I hope this helps somehow. All right, take 2 for video number 2.